delicious food, very kind people, and I've been to many conferences around the world, Europe, the US, all over Asia. This is definitely world class, so congratulations to the organizing committee and all the sponsors. So today, I have a very broad and large topic. When I was told I had an extra hour, I was actually very excited because trying to condense everything I wanted to share in 1 hour was becoming very stressful, so it was a relief to hear I had an extra hour. So the title of my presentation is The Pink and White Journey in Dental Implants Towards Optimal Long-Term Success. So dental implantology, we talk about implant survival and implant success. And I think all of you would agree that the type of work you want to do for your patients and the type of work your patients want and deserve is implant success. They don't want an implant that's going to have complications right away, in 1 year, in 5 years. And how confident are we that we can have minimal complications at 10 years, 20 years? So let's keep that in mind. For the disclosure, I do not have any leadership or financial relationship to this activity. My opinion, the opinions expressed in this presentation are my own, and they're not the official opinions of any of the organizations that I work in. Commercial bias, I want to thank the sponsors of this event and the lecture, Vietnam and Med Park. And all these images are unadulterated except for basic cropping. So bear with me. Hai choi toi một con tum cho toi chai. So thank you. So what I hope to do today is to show you a road so we can accomplish successfully and predictably this difficult task of the long-term implant success. So I did specifically look for a road here in beautiful Ho Chi Minh. So unless Google lied to me, that should be a local road. So here's our road for today. So when the patient comes in, the first thing we look at is the soft tissue before we do any imaging. So that's the thing we can see clinically with our eyes. And at that point, we need to make the decision, is the tissue in good enough condition that we can start doing hard tissue analysis and grafting? Or is it such bad conditions, such a challenging situation that we need to augment even before we consider doing the implant or with augmentation or pre-augmentation? So after that, we do the hard tissue analysis, and then we determine, are we going to augment before we place the implant? Are we going to augment at the time of the implant placement? Are we going to do both? And you can see I've purposely made everything pink for tissue, white for soft tissue, white for hard tissue. And then implant placement, we know we can do everything at one time if it's predictable in that specific case. We can place the implant, we can do hard tissue grafting, and we can do soft tissue grafting. And we know that's the basic recipe for immediate implant placements in the anterior, to do all three. After doing that, if you haven't done a one-stage approach, you get a second chance at the second stage surgery. So the two really big soft tissue things I want to convey is that at second stage surgery, it really is underappreciated, that chance you get to optimize the soft tissue at that point. People say things like, oh, it's a slam dunk, easy implant case, or I'm just doing a second stage today. And so, even with, I've been a dentist for 15 years now and a specialist for 10 years, I still never say that in any case. Every case has my respect, every case is individual. It may be the first implant for the patient, even though it's your number 1,000, 5,000, 10,000 implant that you've placed. So a case like this showed up. There's a 19-year-old young soldier, and he had an implant placed at number 9 at a private practice in the US. And we can appreciate that there's problems even without looking at the radiograph. So the implant has caused bone loss for the neighboring teeth and now has made the lateral incisor, number 10, hopeless because of the amount of extensive bone loss. And so you thought it was bad on the buccal, and usually the buccal is the worst, but look at the palatal. So we can see the implant was placed way too deep. There was probably not enough bone to begin with. And now we clearly have a huge hard and soft tissue problem. So in this kind of case where we have so much soft tissue missing, we need to do soft tissue grafting first before we can even consider reconstructing the rich hard tissue. So in this case, we did this VIP CTG graft, so that's a vascularized interpositional pedicle. So the nice thing about this type of technique is it has a blood supply to your connective tissue graft, and it will give you the biggest volume possible because of that. So for this patient, you can see at the 10 weeks, now we've gotten to a place where we have enough soft tissue quantity and quality that we can consider hard tissue grafting, where if the patient is happy here and just wants to live with a fixed tooth-borne prosthesis, that's also an option. And on this slide, I could have posted tens or hundreds of cases that we see like this, where we clearly see there's a hard tissue quality and quantity problem. We have a shallow vestibule, and we know there's bone loss underneath this implant. So we have to ask ourselves, what is the etiology? Is it just soft tissue? Is it hard tissue? Is it surgical? Is it the patient's medical history? Modifiable risk factors? And so a more focused question is, what are the risks for peri-implant disease and defects? What are those risk factors? So luckily, very conveniently preparing for this lecture, just last year, the AAP, the American Academy of Perinatology, and the Academy of Osseointegration got together underneath the vision of Professor Hamle Wang, and they came up with a consensus. And so in finding all the papers, they came up with 4 systematic reviews and meta-analyses. And so you can choose to read these, I have in detail, but this is very difficult reading and takes a long time. But luckily they also had the vision to create a clinical translation paper for the working doctor. So in that paper, they talk about the risk for peri-implant disease and defects. And they did something very, very nice in that paper where they created these beautiful charts where they tell you the risk marker, the evidence, is it statistically and clinically significant? Did the people in the committee come to a consensus and clinical considerations? So we'll briefly go over all of these because my hope is in the very case presentations that I'm going to show you is to organically cover all of these issues, and hopefully that we've gotten these perfect in those cases. So we know that we want to place our implants, especially in the anterior, more towards the palatal. If you're too buccal, you're going to have an issue. In the posterior, we know we want to center it, but in the anterior towards the palatal. We know not only the buccal palatal location, but also the angulation. So, and many times with the ridge anatomy, it's challenging. We have to angle it, and then your path of emergence is coming out the facial of the prosthesis, and we know if it's too facial, you're going to have a difficulty restoring without recession. Here is like the story of the 3 little bears, Goldilocks. We don't want something that's too hot or too cold. So in this case, we don't want something that's too shallow or too deep. If you go too deep because you don't have bone, then because of the funnel of resorption that can happen around the prosthesis, you're going to cause issues for the attachment of the neighboring teeth. We also know we don't want our restorations not to be too convex. If it's too convex, it's going to block out and crush the room for the soft and hard tissues. And then we know if we place the implant and we start with a buccal dehiscence and we don't do something about that, we're going to have issues. Going along, So for the soft tissue, we've always talked about the keratinized tissue, so the attached mucosa. We know we want at least 2 millimeters. If it's less than that, or we have unattached, we're going to have issues with mobile tissue and the quality of tissue. But now, with further evidence, specifically the studies from Professor Linkevicius, we know we also need enough tissue thickness and height. And so the magic number really is about 3 millimeters. So if your implant's too shallow, or you don't have enough tissue height and thickness, then the body is going to reestablish that biologic height or width. And even if you've regenerated all this bone, the body's going to take it away. Okay, so we know immediate implant placement comes with its risks, specifically in the anterior. It's more prone to midfacial recession. We'll talk about strategies for how to deal with that. And then we know if the longer it's in function, as I was saying in the beginning, the higher the risk for issues. But I argue that that does not have to be the case. Okay, splinted implants can have more risk of bone loss than non-splinted implants. Platform switching. So we know if we do platform switching and have a conical connection of the implant design, and the gap is moved away from the edge, along with enough soft tissue thickness and height, that we're going to minimize bone loss. Okay, and then prosthetically, recently a lot of the evidence again has come talking about the convexity of the restorations. We know that if your restoration angle from the implant is more than 30 degrees, you're going to have bone loss, no matter what you've done. So we want to make sure we come straight and then less than 30 degrees, so give room. And here it gets a little repetitious. So let's move on to showing how we address these things. So if we boil all of those risk factors down, we can come up with this saying, that the bone sets the tone, the tissue is the issue, but pros is the boss. So normally the saying would stop right here, and this really ties everything together. So we know we start with treatment planning, prosthetic treatment planning, so crown down treatment planning, and then we end with the prosthesis. So if we don't plan and we don't get the prosthesis right, no matter what we've done biologically, we're going to have complications. And I just want to tie up front that zirconia is the most biocompatible material in the submucosal area. So if you actually want hemidesmosomal soft tissue attachment of your epithelial fibers, you want to have polished zirconia below your gingiva. So a tie base and polished zirconia. Titanium is fine, but the evidence clearly shows that zirconia is the best for actual attachment. And we know that's important because the soft tissues around an implant are just scar tissue. We don't have the attachment the way we do around the tooth, having those connective tissue fibers going into the cementum and blocking out bacteria, minimizing inflammation. So here we get some kind of pseudo attachment in lieu of having actual soft tissue, connective tissue attachment. Okay, so I showed you the road in colors, in white, pink, and white. So all the cases I'm going to present up front, I'll show you what I did. So bone, soft tissue, and the capitalized white is the prosthesis. So are autogenous tissue still the gold standard? Or in this case, is autogenous bone still the gold standard? The answer is yes, and no, or maybe. So depending on how you use it. So block grafting in the traditional sense, I don't do. It has its complications. I use specifically the quarry split bone block grafting technique because we talk about biomimetic dentistry and considered in surgery. This is true biomimetic dentistry where we're creating cortical bone, and in between we want cancellous bone because we want that blood supply. With a traditional thick block graft, what you get is just cortical bone, and the studies talk about the bone resorption. Of course the bone's going to go away. It has no blood supply. And so if there's no blood supply, there's also no immune responsive protection to around your implant if it has problems. So that's my answer to using autogenous. So treatment planning, crown down. So I work with a comprehensive team. I work with comprehensive dentists and with prosthodontists. This was a comprehensive dentist that treatment planned this. So here we can see, if we want to be successful, we have to analyze everything. We have to know what we want our crown to look like, the distance from the crown emergence to the implant platform. Again, at least 3 millimeters. Here we're going between 3 and 4. And the 3D position of the implant. And so we know here, this is prosthetically driven, and we know we're going to have all this implant dehiscence. So we get ready with the right treatment. And we know the answer is not to try to place it deeper, because too deep is going to cause problems. And if we don't graft, the evidence shows we're going to have problems. We don't just want to compensate with soft tissue. So in this case, if you've seen the work of Professor Luca De Stavola from Italy, he's been a pioneer in the field of digitally guided block graft harvesting, so you can be safe. And so here you can see everything, again, in 3D, the planning for not just the guided implant placement, but also the guided harvesting with piezo of that block graft, so we know we're not going to cause any injury to the nerve. So all this was planned in ExoCAD and then 3D printed. There's great value in physically seeing this reconstructed in this digital software, but then also printing it out, which we'll see. So when we look at this case, it doesn't look very impressive. It looks like just an average case. We have decent soft tissue. It looks like it's thick, definitely enough keratinized attached tissue. It doesn't look like a big defect, but because we did the CBCT analysis, we know what we're getting into. So fully guided dental implant placement, we use the Densa Burr and the Densa Burr specific guided system in our clinic. So here, trust, but always verify. So we know we want to do all this digitally planned, but we also need the analog classic surgeon skills if we get in trouble, because sometimes you go in there and things don't fit. And so you have to have the confidence and the training to be able to potentially go without it, or if it's not helping you the way you want it to, then verify. So trust, but verify. And so here we spend a lot of time planning and also memorizing, and we have everything up in the surgical suite so we can compare and see all the measurements. And this looks exactly the way we planned it. This dehiscence, the depth. I really want to bring your attention here to also the importance of measuring the soft tissue thickness of every patient when you reflect the flap. So here you can see it's less than 2 millimeters, the thickness of the soft tissue. So we know that if the implant is placed too shallow, and then when you're combining the thickness of the soft tissue and then that distance, if it's not 4 millimeters or at least 3, you're going to have bone loss around your implant. So there's great value in 3D printing your model, not only for getting prepared before your surgery and seeing how everything's going to fit. So here's the guide in place and doing piezo harvesting. And then the added value is, in this specific case of block grafting with the Corey technique, is I can adapt it outside the mouth. I can pre-drill outside the mouth. And then I can fixate it in the mouth. So that saves me stress and some time. Professor De Stavola has gone further, and he has specific holders to actually hold your block graft to guide it 100% where you intended it to go. But all autogenous in this case, autogenous grade used to fill in and just a collagen membrane to protect it. So the beauty of this technique in autogenous bone is that at 3-4 months, you have perfect bone. So it looks like bone, it feels like bone, it smells like bone, it bleeds. It doesn't look like we did any grafting in there. So taking out the fixation screws. So this system is from Meisinger makes this. I'm sure other companies might make it, but the original is a Meisinger. As we can see, the implant was completely buried in autogenous bone. You can see it's bleeding, so we know it has immune protection. And again, if you're not familiar with the classic article by Spray and Group from the VA study, they did a study where they placed the implants, they measured how much bone, buccal bone they had. If it was 2 millimeters or more, at second stage, they saw that they kept the bone, or somehow they actually gained a little bit of bone. But if it was less, you lose bone. So you want at least 2 millimeters buccal to your implant. So we see here we have around 3 millimeters. And so we did all that work to regenerate the bone, and we're not going to forget about the soft tissue grafting. So in this case, since we had enough attached keratinized tissue, we just did inside the flap, adding the connective tissue graft. And so immediately, it doesn't look like we did much. The width doesn't look like it changed much immediately. But connective tissue graft, we know in dentistry, it's the only thing that gets better with time. Everything breaks down with time, everything else, but connective tissue, soft tissue grafting, autogenous, gets better with time. So this is the ugly duckling stage at 2 weeks, just to show you. So when you do it in your practice, you see this, you don't want to cut something off, or you're worried, oh, it doesn't look beautiful. It will look beautiful for you. You just give it up to 6 weeks, 2 months, and this is what you get. And now you see the before and after, you can see the big difference. So here I really want to drive home the point, and you're going to see it in my other case presentations, that you can have 2 centimeters of bone underneath your flap, and it's still going to look deficient. So you need to do the soft tissue grafting to get the stage for your prosthesis to shine. If that's not clear in everyone's mind. And so we can see the healthy soft tissues around the implant and enough height. And so, again, a beautifully designed, zirconia prosthesis on a tie base with polished zirconia and then characterized on top. So you don't want to put any glazing material. This has to be highly polished. And so this paper by Dr. Gomez Meda is generally quoted in the anterior, the biological contour concept. And if you do the bone and the soft tissue right in the posterior, then it can apply to your prosthesis in the posterior as well, that you want this zone to be straight, and so that's going to leave room for your bone and your connective tissue to be in there. This zone is going to leave room for your soft tissue thickness, and this zone, the aesthetic zone, ends up determining where your margin is going to be. And so this is at the day of prosthesis delivery. So everything looks great. The patient had to move away the next week. But I would have loved to see this continue to fill, as we know it will, in this kind of situation where we have the bone and the adequate soft tissue quantity and quality. So in implant dentistry, it might have become, I know it's now maybe obvious to the more experienced clinicians, but maybe not so much to the newer colleagues in the audience, is that if you show me a 2D image, that's nice and that's necessary for documentation. But if you don't show me what it looks like in 3D, I can't really tell you the long-term prognosis, because it may be a ticky time bomb and we don't know it. So 3D follow-up and seeing that you have the thick bone, and then if you put a cotton roll always where you're trying to follow up, then you will also be able to then measure the shadow of your soft tissue. And so here we can see that we have the thick bone, but we also have over 3 millimeters of soft tissue height and thickness. And so I try to show these when I do study clubs, when I teach the residents, when I teach other dentists, just so you see that I'm not taking the best snapshot, but you're seeing that through all the slices, what it really looks like. I think it's easy sometimes. And again, I have a lot of complications and failures over the years, especially when I was learning. So I hope that by showing you this experience, it can give you some wisdom so you can make less mistakes than I did. Too many times I see you cheat your prosthesis to the lingual and then you don't have enough room for prosthetics. It'll end up emerging too soon, and then you'll end up with a long crown on the lingual. So it has to be perfect buccal and lingual, not just buccal. Because then the patient is going to have a difficult time keeping this clean, because you get closer to the floor of the mouth, and then it's not, you want that even junction on the lingual as well. And so we went through all this effort, and this is as good as we can do for a delayed or late implant placement, someone who came in when the dentulous ridge. But you still see it looks amazing, but it doesn't look perfect. And I'll show you the only way you can do it perfectly is with immediate implant placement. So as I mentioned in the beginning, our patients are all individuals, and a very important part of periodontics and implant dentistry is the history. So you want to listen to your patient and see what they've gone through, what their road and their journey has been with their oral health, and maybe a specific implant. And that's what I want to exemplify in this case. And also the grafting material that really helped us out is this moldable xenograft by Ben Park, which you'll be seeing the results here. So this patient came in. This is a high-ranking patient. Very nice gentleman, but I'm a lieutenant colonel, so that's 2 ranks below a general. This guy was 1 rank above me. He's a full colonel. 1 rank below having a star on his chest. Very nice, but you can see back here in 2019, it's a bruxism patient. He didn't have any large restoration, just a small interproximal, and he fractured the mesiobuccal root. And then here you can see at 8 months, the old style of planning before digital was implemented for that provider. So again, these I dug up from our system, just the x-ray system. I did not have access to the clinical notes, but we can infer a lot from the x-rays. But in the repository that we have the largest, we like to joke that we have the largest group practice in the world, in the US military. So larger than any private group practice, and free treatment for all our patients. So you can see here that as they're planning, it looks like something went wrong with the extraction or ridge preservation. We have a bone defect already. So then they place the implant, looks good, and it looks like they did bone grafting. Soft tissues in here, looks good. One thing I want to say is, in the literature, and you see all the top speakers and professors saying this, you do a surgery and you say, primary closure. I got primary closure. Look at my surgery. I got primary closure. We're all doctors. And I feel like in countries like Vietnam or in the rest of Asia, they go more through medical school. And so they're more in tune with the medical colleagues. And in medicine, there's no term primary closure. There's no real term. There's primary intention healing and secondary intention healing. And I won't go into the third one. There's a third one where there's war injuries that we intentionally leave it open. But I want to drive home that point, because if you get closed and it doesn't stay closed, then it's not primary intention healing. So here we can see that just 6 weeks later, the patient came back. They lost their bone graft. And unfortunately, I don't know what they did surgically, but the bone did not the implant did not integrate. So they did another bone graft for the patient. And then finally, 11 months later, second implant was placed. And another mistake. They put a very wide healing abutment. And so we talk about the final prosthesis, but please don't crush your bone with the wrong healing abutment. I know most companies are now making these aesthetic abutments that are well designed, because studies like this have shown that if you use an anatomic abutment and you get too close to the bone or come out too convexly, you're going to lose your bone. Like this. So they decided, I guess the patient had been through enough. Let's restore the patient. So it looks like a custom tie abutment and a PFM crown. But again, we have no 3D imaging of this. We just see a bone defect over here. It doesn't look good, but it doesn't look horrific. It just doesn't. It looks like not an ideal case. And so this is a ticking time bomb. They decided, we want to switch to tie-base. So they switched the restoration. 1 year follow-up, it's surviving. This is not success. This is surviving. Because sooner or later, and unfortunately many times sooner than later, we have issues like this where the patient is in pain, it's mobile, and then when the patient finally gets to me and I have to explant because of the pain and the mobility, we know it's a failed implant. It looks like this, with this massive peri-implant bone loss, and there's been, unfortunately, significant attachment loss around the neighboring teeth that is near impossible to regain, but not impossible. But in this case, we can see the implant had actually horizontally fractured, and that very, very successful integration in the apical third. And then from the inflammation, all this was easy to take out. We just see bacterial biofilm on that implant. And so here we see the unfortunate aftermath, the consequences of things not done for implant success. And so at this time, we just did some very basic grafting using the important principles of creating stability with the tacking. We use a collagen membrane. Under here, in the defect, we ended up using an allograft so we could get faster turnover. And so here we can see 3 months later, we can see we've regained a large amount of the bone. It doesn't look bad, but we have to look at the soft tissue. So this looks terrible. And again, as I mentioned, attachment loss on the neighboring teeth, attachment loss over there. So what do we do? Well, at this point, after the analysis, we decided we can do the implant, but we're going to need white volume along with the implant. So in this case, we placed this time a wide platform implant, because before they had placed a regular platform implant. So patient with bruxism. And then from our planning and our guided system, I knew this was the depth we wanted to go. I have dehiscence. Why don't I just place it a little bit deeper? Then I don't have to do any bone grafting. It'll be okay. So that's why the planning is important. You know you're at the right place. Stop. And now you need to do something with bone grafting. So here we use the S1 moldable bone graft. And then at just 10 weeks later, so that's just over 2 months, we know the bone is stable, and I did a split thickness reflection, leaving the periosteum, protecting the bone. And because of all that soft tissue deficiency and volume loss, I know I need to do 2 rounds of soft tissue grafting for this patient. So the patient did not want to go through block grafting because they've been through so much already. That's why we turned to staged allograft. That's something like a long-lasting xenograft. But I told the patient, hey, you have to compromise with me here. You have to help me help you, because if I don't do 2 rounds of soft tissue grafting, you're going to lose all that bone that we created. And so the patient, nice guy, was very understanding. And so here we have palatal tissue graft and a tuberosity graft. And it's really important that we appreciate and know about the biologic differences of these soft tissues from the different areas of the mouth. This one is a lot denser and will proliferate a lot more than the palatal tissue. And so we took both because we wanted to use the specific technique from Professor Urban and colleagues, the iceberg connective tissue graft, which is an amazing technique for regaining papilla plus soft tissue height. So when you're suturing these, this buccal occlusal line angle is the place that you want to stabilize it. And over here, the tuberosity graft is sutured to the palatal graft. And so passive wound closure, this is not, I never call it primary closure. We can see the big difference just immediately. And then it stayed closed. And then the tissue proliferated. Again, this is the ugly duckling stage that I showed you before. This is going to settle. So another thing I don't agree with is you show too short term on Instagram or TikTok, and then you're like, look, I can grow it above the teeth. But early on, there's inflammation, and the story will unfold. If you have enough bone support, it'll stay there or it'll come down. So as I told the patient, now we've got enough soft tissue thickness and height, but anytime we do a GBR or any connective tissue grafting where we're closing and we're advancing the soft tissues to close, we're ruining the mucogingival line angle and the depth of the vestibule. So we're going to have to reestablish it. So that's always important to remember. If you're doing that, you're going to have to apically position and reestablish your vestibule. So that's what we're doing here with a free gingival graft. So at the same time, we do a minimally invasive incision to then get at the cover screw and place a narrow healing abutment. And we place a large free gingival graft. So I extended it very generously to the anterior tooth as well, and the posterior one, to help those teeth as well. So you see here what it looks like. I'm just trying to show you every view. It's important to assess yourself and document from every view so you can learn and communicate with the patient. So here, what we're looking at is the bone we have now in relation to the platform. You can see the bone is actually a little bit above the platform. The day of implant placement before doing the S1 grafting, you can see that, as you saw clinically, that we were right crestal, there was no bone above, and now we've actually not only gained thickness, but actually gained a little bit of height. And now you can also see in the shadow the soft tissue height before and after. But here you see it clinically. This is still in the healing stage at about 2 weeks, just like the previous case, ugly duckling stage. But before and after, a huge improvement. And then give it a little bit of time, and the duck will grow to be a beautiful adult. And so here, I want to draw your attention to the deficiency we had even at the premolar, and now we have a very nice convex line going all the way because of our staged and multiple soft tissue grafting approach. So the tissue is going to settle, so you have to overdo it. So basically that's saying shoot for the stars and you land on the moon. So this is what you want to go with. You're doing good on time. Okay, so here I want to show you the gain that we had. So, you might see a fancy car on the road, but you always want to look underneath the hood to know what's really there. Maybe the car that doesn't look so good has an amazing engine. We want both. We want the outside and the inside to look good. But here we can see, again, it's just 3 millimeters that we've gained, but in establishing that 2 millimeter parameter on the buckle of the implant, if we placed it here and didn't grab, we were going to have a dehiscence. So 3 millimeter gain all the way across. As you can see here, not a big concavity, but it's been completely dealt with. And now we have a straight convex ridge going all the way across. And again, just showing you the slices. So you know I'm not showing you the best slice to try to cover up or make the results look as good as possible. So the capital white, again, a beautifully designed final prosthesis for this patient. Zirconia on a tie base with the polished zirconia in the subgingival area. Studies have shown that, again, this is the only material that if you place it, the soft tissue will actually grow up, has the potential to grow up over time on this material because it's so biocompatible. On titanium, it can hold the level, but it's never going to grow up further on you. So if you want the final chance to improve things over the long term, then you use the zirconium. And so here at the date of delivery, you can appreciate the health of the soft tissues. And again, the convexity all the way across. And you can see we have just enough 3 millimeter height to protect the bone underneath. And so prosthesis in place. And again, when you have a large defect, you can never get back to perfection. It's nearly impossible to do. And so the best you can hope for is this kind of scenario where you have, again, well supported. Again, here you can see on the buccal, we've reestablished the vestibule, and you can see the continuous mucogingival junction with convex tissues. And then you can see immobile tissues. Too many times we do this, and the margin is moving up and down, up and down, up and down, and the bacteria is going in like a water park, having fun. So again, the before, and this is before, after grafting initially, and then the after adding the xenograft and 2 rounds of soft tissue grafting. Okay, so in this case, so there again, to drive home the point is sometimes you need to do not just 1 time hard tissue grafting, sometimes you need to do 2 times for very challenging sites, and many times, again, please, 1 time is the minimum for soft tissue grafting, but for challenging defects where there's been, again, disease and peri-implantitis that has to be in a failed implant, and you're starting over, you're going to need to do 2 rounds of soft tissue grafting for long-term success. So I want to show you the versatility of this material going vertically into the sinus. So this is not a sinus lecture. Again, the sinus lecture needs to be at least 1 or 2 hours, but we know a sinus congress can last days, a full day intensive course. But what I want to show you here is, again, I really love these densiburs. In analyzing this sinus, we have the anterior wall of the sinus sloping, so that's where we needed the anterior implant. And then we have a septum. So when we analyze the risk factors for perforating the Schneiderian membrane, we know an angled floor, very risky. We know a septum, very risky. And these burrs, with the right technique, which we don't have the time to get into that today, allow me to go into the sinus without perforating in these challenging situations. I'm sorry. And then again, we see these in 2D. So if you get this in 2D, the dome and a lot of bone graft in there, that's great. but we need to see it in 3D too to see the full story. So in terms of the ultimate numbers, we had a decent amount of bone, but we wanted to place a sufficient length of an implant. Short implants are fine, and in select cases, but in this area with the bone quality and the terminal teeth, and we didn't want to splint them, we went the full length implant. So here, 3.5 months, 11 months, you can see that graft has continued to ossify over the longer term. And then, again, this is not a sinus lecture, but always analyze in 3D the width of your sinus. So if it's less than 10 millimeters, the narrower it is for indirect grafting, you're going to get a beautiful 3D dome in that area. If it's greater than 10 millimeters, if it's a wide sinus, it becomes more challenging to get graft all the way across. But we had sufficient graft surrounding the implant. And so again, showing you in every view possible so you can appreciate the full story. You can see the before and after. And in 3D, you can see the empty sinus and you can see the anatomy of the bone that we filled in there from mesial to distal, from that anterior wall to the septum that was blocking the posterior area. And so again, at 11 months, just running through the slices, you can see up here, integrated bone, and no inflammation in the sinus. And again, in 3D, sufficient bone on the buccal over here. This poor premolar is having some issues that we're going to have to deal with. And again, just showing you clearly what that looks like. And so looking at the patient from the outside, coming back to the soft tissues, this patient refused soft tissue grafting, but fortunately they had enough thickness to begin with. When they refuse, we can get predictable long-term stability, but we're not going to get that beautiful volume that's approximating a natural, completely natural appearance. We could have made these a lot shorter and a better emergence if he had allowed me to do connective tissue grafting. But luckily, you can see here, underneath, this is about 8 months after the implants were delivered. You can see adequate abutments at the time of second stage. And then you can see with the prosthesis, again, this is polyzirconia. You can see that the bone is still above the platform level and doing very well. And you can see the shadow of the soft tissue height, which looks to be 3 millimeters or more. And so the evidence for this, and Professor Linkovicius, either read his articles or get his book. You can see in these studies, implants place healing abutment. If you have 4 millimeters of soft tissue height, you get no bone loss. If you have less than the recommended 3, in this case 2, the body is going to want to reestablish that supracrestal attachment height. And so note the differences between patients. Some patients, and again, if you lose bone, we know soft tissue fills in. And so we'll have, this patient has less bone height and have thicker soft tissues. This patient has a lot of bone height, but very thin soft tissues. So you have to analyze that, and then you have to design your prosthesis, and then that'll inform where the implant height needs to go and what you need to do with the bone and the soft tissue. But just eyeballing it, again, you have to, it's very difficult to do, even for a master. And so here you can see that attached tissue, which is greater than 2 millimeters. And then just a very basic video with the iPhone, you can see those marginal tissues don't move. So this is a very stable scenario for the long term with all the interventions. Same patient, lower right. So in this case, you can already start seeing the abutment, and you can see the mucosa at the crest. This is not a stable situation. We're going to have to deal with this for the patient next. So this implant's replaced by someone else. You can see it's not just an issue with the soft tissue quality and quantity, but in a rough analysis of this, they placed definitely this implant too shallow, but I argue that this implant was placed shallow as well. So again, too deep is bad, too shallow is just as bad. Unless you're using some kind of tissue level implant, then obviously that's the indication. Or if you want to do that, then you need a polished collar over here, but you definitely don't want threads exposed over the bone. Okay, so this is the classic recipe for immediate implants in the anterior. The implant, bone grafting, soft tissue grafting, and at the end, a nice restoration. So this patient had trauma. Someone punched him in the mouth. Some drunk guy punched him in the mouth. And so our endodontics department brought him in, did the endo, splinted him, stabilized him. And they did an amazing job getting the irregularities. But several months later, the fact that there was a fracture at this level came to light. So it was breaking down, and this actually ate a lot of all of the buccal bone plate. So when we're analyzing, if you have enough experience, in the lower anterior, we know we have that scalloped appearance. And then this is not an ortho lecture, but there's the perio-ortho connection as well. So surgically assisted osteogenic orthodontics or periodontally assisted. We know that depending, you make your analysis and you want your teeth to come buccally, you need to add bone, not just soft tissue in many cases, depending on how far buccal you're going to go. But this patient showed up, and I was impressed at the level of scalloping. So as we go through and analyze, we know this bone is very thin. Look how thin it is. We know in over 90% of cases, it's less than 1 millimeter. But also, the distance from the CJ to the bone is 5 millimeters. Plus, the interproximal bone is not helping us. Very scalloped. So very challenging case. So not a good case for an immediate implant. Why did we still do it? Because of experience and because we have a recipe that we know works, and I'll show you my recipe. So this does take surgical training. So a disclaimer that for any technique, you want to start off with low risk scenario, do the challenging technique, and then apply it to a high risk scenario. So you know you've gone through it, you know it works in your hands. So that's my advice to the younger dentists, the younger specialists. So here again, just showing you in 3D what you already saw in the reconstructed, that bone dips interproximal on both sides of that tooth. So here's what it looks like clinically: splinted, recession everywhere, rolled border, inflamed over here because this tissue is hanging on for dear life because of the lack of bone. So again, when we talk about immediate implant placement in the anterior, we're worried about midfacial recession. Well, we already have the midfacial recession and the challenging bone situation. When you look at your cases, consider the convexity so you know what you're getting into, what's there before, and you can really assess your outcomes afterwards. So we took out the tooth, no problem at all on that one. And then here you can see that we had no buccal bone plate. Place the implant to the palate, so we're leaving enough room here. So these next two pictures are from a different case, but it's the same thing that we did in this case. So I learned this from Professor Joseph Kahn from Loma Linda, not in person, just watching him online, when he showed a challenging high smile female immediate implant case. You don't want to ever want to cut the marginal tissue, so you hide it in the vestibule with a tunneled graft. So we did, in this case, 2 vertical incisions. You could do just one, and then you put a thick, a more rigid collagen membrane, and you pack your bone underneath. And then we knew we had recession, so we also did the connective tissue graft at the same time. So this is what that looks like. So at 3 months, we saw the patient. The last component, and as I mentioned, the most important, the prosthetics, is if you're not going to do an immediate restoration, at least do a custom healing abutment. So this is quick and dirty, but it supports the buccal and the interproximal soft tissues. And so you can see the tissues look okay. 3-month follow-up to see what the bone looks like. Looks like we have bone. It's still maturing, but looks like we have bone. This is just the very short term. We'll keep going through this. So in comes my prosthodontist. It makes a very nice provisional crown now to keep training the tissues. But here you can already see that we have a problem. We see it's coming out the cingulum, and beautiful soft tissues now after his provisional crown retrained it. And again, same recipe for the prosthetics. So we have a problem. We've made the patient asymmetric. We did too good. We started off, he looked symmetric, and now we gained too much over here. So we have a problem. So this doesn't happen in all cases, of course, but it happens in most cases for us because of this recipe that I'm showing you, where it wasn't. So the usual recipe is the implant, and you're placing bone where the socket was before. What I'm trying to tell you about this recipe is we're doing ridge augmentation at the time of the implant placement. So I'm placing bone outside of that housing. And here I needed to because we saw that we were deficient on either side of the direct buccal. But here you can see close up the quality of the tissue. It's stippling. Not all patients have stippling. The absence of stippling doesn't mean disease, but the presence of stippling we know means health. And so you see we've actually gained attached tissue, where here we barely had any attached tissue around that tooth. Just moving through this because I want to show you the long term. So this is 1 year, 4-month follow-up. So again, I didn't post any of the 8-10 year cases because I wanted to show you the working process here. But when we look outside, we see a very stable situation, and we'll see what it looks like underneath the hood. What I want to say is, so here, jokingly when I'm talking about the problem that we created, it may sound cocky, but I was also humbled by this case because I thought, let me make him symmetric. And I did a beautiful tunneled CT graft here. And I also did a second free gingival graft here. In the beginning, and because of the sake of time, I didn't include all those pictures, but you want to take those pictures over time to see, oh, I got full root coverage. But in cases like this, the tissue can actually go down over time because this is what it looks like underneath. I mean, a lot of cases of recession, we know we have dehiscence, but this is extreme, and the tooth is pushed outside of the arch. And here we can see we've actually dramatically changed the phenotype of the bone that the patient came with, because now we have good bone all across. So I was not able to make the patient symmetric with treating the other side that he initially didn't come in for, because there's no bone, and I didn't think to put bone there. So that was my shortcoming. In most cases, that's not the case, but it's important to know that there are enough of these cases to look out for, that it would require hard and soft tissue grafting even around a tooth, which sounds crazy because a lot of people, publications and on social media, recession, just soft tissue, looks great. But in the most severe cases, consider that you need both, just like an implant. Because again, here you see the difference before and after, and then this has stayed the same. And then when I'm critically evaluating my cases, but other people's cases, I want to see this. Show me the sagittal scan. Show me the before and after from a fixed reference point. So the bone crest, 14 millimeters from the anterior nasal spine, 14 millimeters from the anterior nasal spine, maybe a little increase. The width has stayed the same too. The soft tissue thickness from the connective tissue graft, you can see, has dramatically changed the phenotype of this patient, protecting this bone, but also this bone, this thickness is now leading, supporting this soft tissue thickness. Sometimes, many times, you can overcompensate with just the soft tissue, as Cordellini, Gamborena likes to show, and then other of the great Italian classic Italians. But this is his full smile. This is a high-ranking sergeant. Maybe he's trained himself not to smile the whole way so he can look mean to the soldiers. But he looks amazing. We know if you lift up the lip, he looks amazing. But this is not a high... We could have done so work, and he would have been fine smiling in front of people with nice prosthetics. But what about a case like this? There's no room for error on a case like this. This is a young captain, very attractive female, late 20s, and she has a problem, a big problem. And so in this case, I want to show you something I'm very passionate about, which is leveraging biology. So in this case, it's implant biology. So no hard tissue grafting, no soft tissue grafting. This sounds like I'm contradicting myself. I just told you the importance of hard tissue grafting and soft tissue grafting. But hear me out. And of course, we always need the capitalized white. So, paradigm shift. What's a paradigm shift? Where we change the way we think about a problem, our approach to a problem. And so, bad perio joke, but I want to tell you about a paradigm shift for implantology. And that a hopeless tooth is not always a useless tooth. And that if we're saying in our practice that we want to do biologic dentistry, conservative, long-term aesthetics, long-term success, atraumatic extraction, minimally invasive, this is something you would be at a loss if you do not try to at least learn about it. So, atraumatic extraction, there's no such thing, because to a periodontist, when you take out a tooth, you're ripping out the PDL. And a periodontist somewhere cries with every tooth taken out. So, using one of these systems, we know there's only vertical forces. A tooth pops out. The tooth was not luxated in any crazy way. So this is as minimally traumatic as it can be done. And even when it's done like this, we know from the classic studies from Araujo, very elegant studies from Chapuis, that in the grand majority of cases, we're going to have this, even if we take it out with minimal trauma. We're going to lose the midfacial plate in most cases, unless it's thicker than a millimeter. And Araujo has showed in the dog studies what happens on the buccal. That bundle bone goes away, the convexity and the horizontal dimension goes away. Bundle bone is just a histologic term, and with very thin bone plates, especially in the anterior, then the bundle bone makes up the majority of the plate thickness. So take out the bundle bone, take out the tooth, you take out the periodontal tissue complex, because it's not just a ligament, it's the largest supply, the blood supply to the bone. So if you take out the tooth, you start an inevitable sequence of events. You're going to lose bone. And so something I became passionate about, I started doing these cases in 2016, so almost 10 years now. So I only have cases with almost 10 years of follow-up. But this is a suite of therapies. Actually, partial extraction therapy with root submergence has been happening since the 70s. Below removable dentures. Back then, they already knew that the only predictable way to preserve the bone and the contours of a ridge for a denture is to keep the root in place. And so, again, I give full lectures on this, and I love to teach hands-on about this technique. But the history of how we went from Phonic Shield and then the Socket Shield article in 2010 from Herzler and group, we don't have time to go over, unfortunately. But this is what I did for this case. So she showed up. This is how she showed up. History of ortho. The orthodontist told her, we can't move this anymore. It's stuck. It's ankylosed. And she was never happy with the incisal discrepancy and the fact that it was a little rotated. So these are not big things. Some people like more malocclusion. In Japan, people like to have the kawaii tooth, the canine sticking out. People like it. My point is, she's noticing very little details, and she has a high smile, and she's a beautiful girl. So if I mess this up, she's going to let me know about it. So there's no room for failure here. So here, looking at what we start with, looking at it that way. And here's the problem. Massive internal resorption spreading to external. So I was looking, and if you look, ankylosed where it's ankylosed with the replacement resorption. So I listened to Professor Chu from Tarnow and Chu lecture in Singapore. And obviously he has his dual zone technique, and that's a great technique. I use that technique as well. But he said that the only case he thinks the socket shield would be great would be in this kind of scenario where you actually have to drill the tooth out because it's ankylosed. So I was looking to see if I had the shield that I wanted without resorption. And thank goodness I did. The resorption had not spread to that area. Here you can see how it spread up here, or just up here. But where I wanted the shield. So we know once you get to the pulp chamber, the root canal system, it's going to bleed. So this is bleeding because of the replacement resorption, the bone in there, soft tissue in there. When I'm in there, I started getting lost. I didn't know where the tooth ended and where the bone started because there was no delineation. But I had done tens and tens. I don't think I've done hundreds of these cases yet, specifically the socket shield. So I used my experience to create a socket, and we placed the implant. We placed the provisional with under contouring, and I supported in here with just collagen tape. So as I promised, no bone graft, no actual soft tissue graft. And take a scan immediately after to see what that looked like. You can see the shield, the dimensions of the shield you can see here. So good palatal placement. The other thing about socket shield is it forces you to go more palatal naturally. So that's another benefit. But let me run through this. This is just, again, it's got that titanium underneath. It looks bad. She kept coming. Why does it look gray? Is it going to look gray in the long term? So we said, we're so sorry, but look at what we've done for you. Without bone grafting, without soft tissue grafting. And so this is with the final, the before and after. And I want to again show you, I argue, and the proponents, the earliest users of soft tissue argue, this is really the only scenario, the most predictable way to get this convexity. Even if you overcompensate with hard and soft tissue, preserving the natural convexity is nearly impossible to do without this technique. But again, very healthy soft tissues, so natural. It looks like the tooth was never extracted. And again, it's inset. You can see even at the crest, the soft tissue thickness, just like the natural neighboring teeth. And so again, one of the last times we saw the patient, I think at 1.5 years. So again, this is not 5 years, this is not 10 years. But what I'm showing you is we have everything in place for it to be successful, for the long-term success. And so this is what she looks like. Very nice, but high attention to detail. And then please anticipate, I will be making a publication, hopefully in one of the better journals of periodontology or implantology, a large case series showing this. How it started, the bone, thin bone, immediately after surgery, the thin bone, 8 months after surgery, thin bone plate still there, 18 months. You can see here in the reconstruction, I'm not BSing you, before and after. This is leveraging biology by keeping that veneer of the tooth, preserving the PDL, preserve the bone. That's the only way to preserve the bone. We get every other technique in implantology, we're overcompensating, we're overbuilding, and that's fine. That's fine. You can't do this in every case, but this is a wonderful tool to be able to offer your patients very predictable long-term results. But again, I'm obsessive compulsive about 0.5 millimeter. Did I preserve all the bone? Did it go away 1/4 millimeter? Okay, so in this case, we're doing an implant plus bone, then soft tissue, and then the prosthesis. So soccer is the most popular sport here? Yeah? Good sport. So I like to call this case bend it like Beckham. So this was not to call out my colleague. So we have an oral maxillofacial surgeon that works with us, and he is amazing because if I don't want to put someone's face together, I can't put someone's face together. And I've seen his work. Beautiful work. But in this case, he took a very simple case, showed up. It was an impacted molar that had left a premolar that had resorbed the molar. Super easy for him. This is, a walk in the park. Took them out, bone graft. What I want to teach you here, hopefully, if you don't already know, hopefully some of you don't, if you most know, then you're doing amazing, is bone grafting can fail. It can fibroencapsulate. And so when you take the CBCT, I should put this case specifically to show multiple things, but this is one of the highlights is please look for this kind of scenario where you see radiolucent areas surrounding the bone graft. When you go in there, you're going to be scraping out all that bone graft. You didn't get bone. So don't walk into a trap thinking, stay closed. It never opened up. We're going to get bone. It's not always a guarantee. Maybe there was some of the follicle that he left in there. He didn't completely scrape it out. Some kind of soft tissue infiltrated this bone graft. And you can see also there's a soft tissue problem. But here, just going through the slices, showing that. Also, another problem is where we want to place the implant. Look at this angle, the slope of the sinus floor. Severe angulation. So, okay, so this is how he showed up to the day of surgery. And here we go. Usually we're worrying about a lack of buccal bone. He's got amazing buccal bone. It's perfect. But he's got no palatal bone. And we know we've got the sinus in there. So what are we going to do? We take out all that scar tissue and then the tensor burrs. Because I know in reverse, they're going to allow me to push things vertically and laterally so I don't perforate. I didn't want to perforate, go out this bone. In this case, I didn't want to drill here because it's too far posterior. So this is as close to the middle as I can get. And we'll see what we're talking about for the bended like Beckham. So we place the implant. We put new bone graft on the palatal with a membrane in this case. And we close them up. And this is how we showed up. So again, repetition to drive home the point. He has amazing natural bone on the buccal. Look at his soft tissue. He never had a bone graft there. Maybe when he did, the surgeon did the removal and the grafting of the palatal, he advanced. And so we have this problem. But you can have natural bone on the buccal, and especially you had a surgery, you need to deal with that. Not good. So here at second stage re-entry, we have bone. We came in kind of quick at 3 months. But before there was a huge defect here, but we got the implant integrated and we got bone on the palatal, which usually we're not worrying about. And then simple apically positioned flap, and then with the right design of the free gingival graft. Here you can see how that's helping from the occlusal view. And then we designed it to fit and help augment this premolar. We're not trying to cover. He did it. He wasn't interested in making the treatment longer, more painful for him. So we just helped it out. And so here's with the healing abutment in place. Here you can see the bone graft. Again, I go through the slices because I'm most critical about myself, but just showing that we got bone all over the palatal surface of that implant. No defect there. And then down there in the reconstruction. Okay. So I don't want to dishonor Beckham, but I feel we did our own little bended like Beckham over here to get the goal in one shot. So thank you for appreciating it. It's a bad dental humor, but so the tensor burrs allow me to do this kind of minimally invasive, highly productive in my practice. So again, the soft tissue appearance. This is what you want your soft tissue to look like. Firm, minimal bleeding, thick, the implant deep enough. So a solid 4 millimeters here. So he's got, that implant has great security forces, soft tissue security forces protecting it. Again, high base, polyzirconia, glazed, characterized zirconia
của chương trình đó.
In its home. You can see what the bone looks like. We have bone over the implant. And the before and after. Again, we've completely reestablished the vestibule. It was down here. That was going to cause issues with cleaning and maybe tugging at the margin. And now everything's even. And it's always most impressive from the occlusal point of view, in my humble opinion. He's got beautiful bone, but this looks terrible. And then same bone, the only difference is we added soft tissue over here and no problems on the palatal. Okay. So I told you the only way to get it perfect is with immediate. So we saw the anterior and a specific technique for the molars. Immediate implant, bone grafting, and titanium in this case. So recurrent decay in the canal chamber, it greatly compromised the interior walls of the tooth. So non-restorable. So they refer it over to periodontics department. I'm analyzing how much bone we have in the furcation, about 2 to 3 millimeters. So not much, and we can see the palatal root is protruding. So here's the bone, but we don't want to place the implant there. We don't want to place it in the middle because this tooth has a gap, a diastema. I want to center it restoratively. So what does it look like restoratively? Right about here, in the middle. Here's what we have, about 2.3 millimeters when we've centered restoratively. So that's what the tooth looked like after extraction. So I section all my teeth, for sure all my posterior teeth. Unfortunately, I can't show you the technique. I use specific fine needle diamond burrs to get it to the PDL and section the root multiple times. And so this is as minimally traumatic as possible. And so we did not go in the middle of the septum. We went anteriorly to be restoratively driven. And here you see the Schneiderian membrane intact. So this is a case of immediate implant with an immediate sinus elevation. Even 5 years ago, I thought this was crazy. So again, you want to pick your first immediate case for a premolar, I recommend, and then your first immediate molar case for a mandibular molar, and move up to a nice interceptal bone. Look at the Tarnow classification for the interceptal bone and the maxillary molars. Don't raise the sinus at the same time in your first immediate maxillary molar case, but you can work to this. So that was a Densiber wide platform implant, stabilized. Here we did bone grafting, and that this is just a collagen tape. The magic here is this custom healing custom healing abutment. If for more experienced people, colleagues, you've been looking at maybe Linkevicius's work, and some companies really advocate create just digitally prepare one already and have it milled and get the timing right. Go full digital and have it fill everything. I'm still of the mindset of Carl Misch, and I think an implant crown should not be like a natural tooth in most of its dimensions. And so I go a little more conservative. And so you can see here the sinus elevation. 2 weeks, 4 weeks, and 6-month follow-up. This patient disappeared a little bit, then we brought him in for the restoration. But you can see it preserved. That's enough to preserve the papilla, the buccal tissues. And so here you can see the story of the bone on the date of surgery, crestal, and then the sinus. And then we've reestablished the sinus floor, and we haven't lost any bone. So titanium is good. Zirconia is the best. And for a healing abutment, of course, you're going to have this titanium underneath here. But look at the bone. There's no soft tissue inflammation, so there's no bone loss. And then here you can see all the bone we got. And then again, I just run through these always just to show in 3D through all the slices how much bone we have. And so this case, these are my favorite pictures, but looking at the funnel of soft tissue. But here, since we placed it a little bit deeper, but not too deep, we can also see this is the bone. Very happy over the implant and the 2 to 3 millimeters of soft tissue. So we have 4 millimeters. It's good. 5 millimeters. Still getting a little deep. 6. You've gone too deep. And so we here centered, and now we've restored it to close the previous diastema. And so, yeah, just a tie base. Sort of a custom titanium abutment, and then the crown over it. Before and after. So 10 months, 1 surgery, 0 bone loss, new corticated sinus floor, improved mesial papilla, right? Mesial papilla, marginal tissue. We actually, in a molar, we improved also the marginal tissue. 2-year follow-up. This patient left. They're somewhere else. I work in Korea. I'm the chief of periodontics for all the U.S. military forces in Korea. There's 2 periodontists. I have another colleague working with me, but here you can see we still have all this bone over the crest, over the platform of the implant. So doing great. Okay, this is the last case, and I think we're doing good on time. So this is the case that the periodontist hates because we can't save his dentition, even with classical periodontal care. I remember as a resident, I did my residency. I went to the University of Pennsylvania for dental school in Philadelphia. That was a wonderful experience. A very storied perio department there. Actually, most departments. And then I did my perio training with the U.S. military in Georgia, at the Medical College of Georgia. And I did my thesis on bone morphogenetic proteins for regeneration, if anyone's interested. But we went to Atlanta, and back then we went to a prosthodontist who was a leader in conversion. So edentulate, immediate prosthesis, upper lower arch. And he looks at me and he says, he was showing a woman who looked like this. And he said, I would like to see you periodontist save these teeth. And I thought, what an asshole. I'm just a resident. But also the patient's chief complaint was the aesthetics. So the periodontist, we could keep the teeth, but if the patient doesn't like the smile, but periodontically he was hopeless too, we have to do the conversion prosthesis to get the aesthetics. But saving teeth is our number 1 priority. But yeah, just did not look good. So the analysis, so here really the most important part is the treatment planning, the digital treatment planning, preparing all the required stackable guides, trying everything in the mouth before the surgery date, and then at the surgery day, you know everything's going to be smooth. But so all the credit goes to my prosthodontist. I'm just a bone monkey. I went in there and I just, like a hired gun. I just do the surgical stuff with extra attention to detail. So here's the tooth-borne guide where we drill the holes for the fixation pins. Then after that, we've drilled the holes. Take the teeth out. So the ones that were mobile, out in under 2 minutes to get to this point for all those teeth. And then here, let me show you something crazy. So I applied PET, the partial extraction therapy, to this case as well. Putting an implant next to a tooth or surrounded by a tooth. Surrounded by a tooth is a little crazy, but in large contact with a tooth, if you put any forces on that tooth, your implant's going to fail. So you would have to do it like this, where just take the straight hand piece and just cut across without luxating the teeth at all. So here you can see just everything being cut. Why do I do this? Again, because preserving the architecture of the bone is going to help preserve more tissue attachment, more soft tissue attachment. You can see here the worst area, all this granulation tissue still from the severe, these are the 2 premolars, just the most severe area. You have to clean all that out. If you leave any of this in and you put a bone graft in there, you're going to get like that case I showed you. And so that's why I showed that case to help drive that point home. So checking the reduction, we have good reduction. Next we stack the initial 2 millimeter twist. So 2 millimeter twist, 2 millimeter, 2 millimeter, 2 millimeter, 2 millimeter went in there. You can't see, but again, it's in contact with the roots here, and it's going to be here. Enlarged. I use the densiburs here and forward still. Forward, reverse, that takes a little feel. Reverse against the tooth is not recommended, so a cut. But make sure I had densified the bone and slightly undersized to guarantee that I get the at least 35 Newton centimeters, but I think we got more like 45 to 50 on all these implants. But just they're at different angulations, so I can only get the first 2 really in full focus. But trust to verify all the implants in place. Huge defect still around this implant. This was the most challenging to get primary stability. Very happy with the position of all of these. And so here, again, I'm working fast. This is a long day for the surgical team and the patient. So I use the S1 graft around this implant, no membrane. It just packs in. After putting the cover screw, pack it in. It sits very easy to handle. No mess. No particles going everywhere. But here you can see the implant in contact with the roots. But those roots were never luxated. So trying in prosthesis, then capturing it. Then, again, this is not my work, this is my prosthodontist work. The patient never appreciates what I do. They always give the flowers and the hug to my prosthodontist. Which is fine. It's fine. I don't need a hug. So here we can see, again, because we preserved all this tissue, big difference for this patient. We did the upper arch first, and then 2 months later, we did the lower arch. But here at 2 months, you can see the quality of the tissue and the contours of the tissue. That's going to help create the contours of promote a prosthesis that we don't have to do any concavities. It's going to be a plaque trap, cause problems, inflammation for the patient. So the lower, the same story, tooth-borne guide, and then we drill for our fixations, and then we fixate our stackable guide base. Did the same thing, just mowed across, and then left root here, 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 here to help preserve as much as possible. Again, thin bone here. This is going to go away very thin. So again, continue going, place the implants, try on the prosthesis before characterizing it. Again, teeth in contact with roots that have never been luxated, and then again using the S1 graft to get this very quickly strategically where we need it. So suturing, he showed up the next day looking like that, and so the prosthesis was delivered the next day. But obviously these FP3 cases, you want to make sure you know where the spinal line full animation goes and reduce above it so you don't show the transition line. And so full animation. So this kind of process. So again, hate to do these. This is hard work, and also hate to take out so many teeth. But This does, when done correctly, it transforms the patient life, not for 5 years, but hopefully when everything done correctly like this is something with minimal complications over the 10, 20-year period for him. And so again, you can see the soft tissue and the contours for this patient. So conclusions, I come back to that quote that the bone sets the tone, the tissue is the issue, pros is the boss. If we dig into that classic quote, I think if you fail to plan, you're planning to fail, especially for the complicated cases. The more simpler case, again, you don't have to, with limited resources in certain clinics, would I place an implant without fully guided? Yes. You just need the experience, that you need to have these parameters, these principles down. But it's always good to have digital planning. But at the very minimum, you need the cone beam and then intraoral evaluation for sure. This I stole from, and then if this is filmed and it gets out on the internet, hi Howie Gluckman, I'm sorry. But this term, optimally invasive, is from Professor Howie Gluckman. So Herzler and Zur are the pioneers of socket shield. But Professor Howie Gluckman has done a lot to make it accessible to the rest of us and to teach. But what does optimally invasive mean instead of minimally invasive? It means do no more, but no less than what you need for the long-term success. So this comes back to many dentists have stress about patient communication. You have to tell your patient, hey, this is what we know is going to give you long-term success. Prevention is better than treatment afterwards for the complications. If the patient still says no, well, you can choose to refuse to do treatment if that you have that ability. I only practice this way in my clinic. Okay, I'm not treating you. Or they have informed consent and they don't come back 5-10 years, and maybe all the patients are nice and they're like, oh yeah, this is normal complication. But in some places you get some patients that don't have the grace, and you did this to me, you didn't tell me, you didn't explain. I did, here's in writing, you signed, I don't want the second connective tissue, I don't want the first connective tissue graft. You can use a substitute allograft, or even collagen membranes will help thicken the tissue. I didn't show that here, but I do that in my practice as well. But optimally invasive. And then be biologically based, and focused, but be versatile and practical. So yes, the gold standard, I'm an autogenous guy. I'm a biologically based guy, so I love the partial extraction therapy, PRF, anything that you can leverage biology to improve the outcomes and the predictability of your long-term success, I'm all for. But we also know many biomaterials, otherwise the industry would not be as big as it is, are very, very helpful, useful, and sometimes they can save and make a case in addition to the biologic principles. So use those tactfully, strategically. And so I thank you for your kind attention. I was told by dear friends here that Instagram is not popular, so I made a TikTok account. I have nothing posted there except my profile, but I do have surgical cases posted. You can contact me here. And if you want to learn about partial extraction therapy, and I'll put in the papers later for the AAP-AO consensus in there. This is just a Dropbox, but if you go in here, you'll find maybe 30 papers on partial extraction therapy. And again, 63 Delta, what's the meaning for that? So in the military, the US military, all dentists are 63 series. We're all 63. So a general dentist is an alpha. Prosthodontist is an F, a foxtrot, but Delta is a periodontist. And in our military, the Delta forces are the special forces. They're actually cooler than the Navy SEALs. These are the people that don't like publicity. they go, there's a mission that needs to be done. They go there, they do the mission quietly. No one knows about it. So the specialty forces are also here to help our colleagues and help the patients. And if anyone has complications, to help our colleagues treat the complications or to treat those complications for our colleagues without any judgment and get the mission accomplished. So with that, I thank you for your kind attention. It's a full room. This is an honor. It was an honor to be invited to speak here. Again, everyone's been so kind and it's been world class. So I think we still have 20 minutes before it's 2 hours. So questions would be greatly welcome. Thank you.
Thank you, Associate Professor Joseph Capetillo, for your excellent presentations about your wide and vast journey. And now we come to the Q&A session. Yeah. Xin lỗi quý vị hội thảo viên là giáo sư Quang trong cái chương trình của mình á, giáo sư Quang vì do thời tiết thì không có bay qua được, nên là sáng hôm nay cái phần đầu á thì còn phần học ngoại tới học ngoại đến 10 giờ luôn đó, tức là học ngoại cái phần đầu luôn. Thì mình còn khoảng độ vài phút, dưới 10 phút để mình thảo luận á. Thì quý vị có câu hỏi gì đặt thì mình đặt luôn.
Okay. Yeah.
Mời bạn. Bác sĩ.
Em cho cái mic.
Quý vị có thể đặt câu hỏi tiếng Việt được rồi này, được tiếng của tiếng Việt còn gì vậy?
Em thắc mắc là cái chỗ mà lúc mà thầy nói là giữ lại cái chân răng á, thì không có cái hình X quang này, không biết thầy có chữa tỉ mấy cái chân răng đó để bảo tồn cái xương hay không?
A delegate has the question. Can you show the picture with the root and you place the implants beside this? Did you do the endodontic treatment before you do this? Before you place the implant?
What type of treatment before placing the implant?
Do the endodontic treatment
Endodontic treatment.
before placing implant.
That's a great question. So if you take a deep dive into that literature, the old one in the 70s and 80s, if it's a healthy tooth, if there was no infection in there or no concern of infection, you don't have to do the endodontic treatment. If there's any concern before, and you're thinking of doing that, you do, but then you want to remove the gutta percha. So it gets a little complicated. So I try to do this root submergence with the non-endodontic healthy teeth. But you don't have to do endodontic treatment if the tooth was non-endodontically involved.
Thầy trả lời là trong cái trường hợp đó thì thầy không có thực hiện nội nha, bởi vì đây là một cái răng mà không có biến chứng, không có nhiễm trùng, cho nên là thầy cố gắng vùi cái chân răng sau khi đã cắt ở bên dưới mô và không có nội nha trong trường hợp này.
Còn câu hỏi nào nữa không ạ? Mình tranh thủ mình còn vài phút thôi. Ông bay một đường dài, mình có cái gì mình cứ hỏi. Nhìn ngời anh Thành.
Cái dương ăn mà thầy giữ lại á, thì sau này đó
cho hỏi là những cái chân răng mà thầy giữ lại á, thì sau này nó có gây nhiễm trùng không?
Yes, he has the question that if you maintain the roots here, it has some infection after that.
So, no. So you have to carefully make sure there's no granules. So the roots that I left, when we analyzed the cone beam slice by slice, up and down, left and right, there was no, because this was a severe periodontitis patient. Those are the roots at that level. There was pristine bone all the way around. And if I were to go back and show you those pictures, when you just sit there and look, you can see beautiful bone all around those roots. But yeah, if they were at all periodontally involved, any doubt that they might be periodontally involved, everything out.
Trong cái trường hợp này thì thầy nói là những cái răng mà mình giữ lại thì mình phải xem xét rất là kỹ ở trên phim CT, phải đảm bảo có những cái phần xương lành tốt ở xung quanh và không có những cái nhiễm trùng trước đó. Và nếu như mà mình có bất cứ một cái nghi ngờ gì về cái phần nha chu hoặc là những cái nhiễm trùng thì mình nên nhổ răng. Còn mình giữ lại thì cái răng chắc chắn là nó phải là răng lành mạnh với xương xung quanh.
I have a question. Is anyone doing partial extraction therapy socket shield in this room? Yeah? Okay.
Tất cả mọi người mình có từng đã thực hiện cái kỹ thuật ở socket shield này chưa?
Hands?
Any question?
Ai có đã
mời chị.
rồi. Các bạn có câu hỏi gì thì cứ giơ tay.
Đây giơ tay lên chị để bạn đưa cái mic cho chị. Chị có muốn hỏi gì với thầy hả? Dạ. Ok. Còn có hỏi nào nữa mà?
Chị bạn không?
Cho người. Dạ có cô. Dạ thầy cô.
Rồi chị.
Yeah.
Is it okay if I take a selfie with everyone?
Yeah.
I have a question.
Yes.
Yeah.
Yeah.
If you keep the roots without endodontics, so the patient would be very painful.
That's a great question.
How
So,
to do that? And then if you during the intervention, you make sure that you have no contamination.
okay, very good questions, both of them.
Yeah.
So,
And how long do you keep these roots?
another great question. So, 3 questions. How do we keep the root? How long do we keep the roots? Forever. They stay there forever. So either they stay stable, or in some cases they undergo replacement resorption and they turn to bone. And then there's always the risk of if you didn't reduce them enough and you don't get bone to grow over them. So that's what we make sure we reduce them enough. They can start erupting out, and that would be a complication. But as they erupt out, bone forms under, and so that's not a bad scenario, but the patient would wonder. So that's the first. The second, in terms of infection control during the procedure, so yeah, it's a surgical site. We can't use a rubber dam the way we do for restorative procedures or endodontic procedures. So our protocol is we always have the patient swish with Paradex for a solid minute to 2 minutes. So that studies have shown reduces the bacterial load significantly for at least an hour afterwards. But copious saline irrigation throughout, and then copious fluid control by the assistants to making sure it's not getting on there. And is the patient in more pain? And so, with the root submerged, with the socket shield, you're getting rid of the whole canal, right? So there's no nerve left, so no pain, no extra pain there. With the root submergence, there's no reports in the literature about pain. And also, this patient didn't have any additional pain to the usual symptoms we see after surgery. And at 10 days, he felt zero pain. Is normal. So that's one of the things. Sometimes a therapy, you think about it, you're like, that's gonna be bad. It's gonna be so. You don't want to be the crazy person to try it without literature. There's someone to do that, or to do a dog study first and then try it on a human. But the literature and then the experience of myself and colleagues who do this, there's no additional or long-term pain. Sorry for the long explanation.
Có song hành rồi.
Hỏi câu nữa. Câu cuối nha.
Yeah, thank you, Professor Joseph, for very interesting presentations. As I want to discuss about the indication for last case, you indicate oral four in the upper and lower, but in the lower jaw, I looked the patient just had a crowding in the anteriors, but you indicate to cut the bone and cut all the teeth and the healthy teeth for the indication 6 implant. But I think that we are the dentists, we need to maintain the tooth for the patient, but indication you cut the bone, cut all of teeth, healthy teeth of the patient. And do you think about this case, over treatment plan in the mandible, oral cyst, and you make the FP3 restoration, but the FP3 and had the problem in the future because it's very difficult for the patient for the clean teeth.
Yes.
Yeah, how do you think about the treatment plans in the mandible in this case?
Yes.
Thank you very much.
Beautiful question. So me and my my prosthodontist, actually, I felt like a bad periodontist because my prosthodontist said, maybe we shouldn't take all the teeth out initially. And then I said, I've wanted a Porsche for 20 years now. So I'm just kidding. So in the military, I get paid the same whether I sit there and drink coffee or I do 3 of these cases in 1 week. I make the same low salary compared to some very good outside providers. So the driving point on that one, stop being funny here, is the occlusal discrepancies. So in the back, there was a lot of occlusal discrepancies. There were some teeth in there that again were periodontically hopeless. So the combination of the difficulties the prosthodontist was going to have with the occlusion, and the last driving point was the aesthetics. So the way he showed those, when he smiles, he animates. The patient, we told him, hey, your occlusion is not going to be as best as it can, and you're still going to be showing those lower teeth. So it was an occlusion driven and then an aesthetically driven decision. You're absolutely right. We could have cleaned them up, kept those lower teeth, tried to do a lot of traditional prosthodontics, but the time we measured it against, yes, FP3 is more difficult to clean. The way it's done in many cases, I wouldn't say most, because many people, the top people doing it, they make it as cleansable as possible. Well, you're right. The patient has to be very compliant and come in, and now they're married to your practice or to a dentist for life to clean it themselves with a good prosthesis and good tissues, but also come in on schedule. You get it taken on and clean. Those were the issues. Great question.
Yeah, thank you very much.
But I looked in the lower jaw, in the upper jaw, and the patient had a periodontal disease and long tooth. We need to give the FP3. I think it's okay. But in the mandible, and I think if we indicate to FP1, maybe the worst better indication for the patient because the FP1 almost easy for the patient cleans and compared to FP3.
Yes. So on that one, on our analysis, because when he smiles, he was doing a weird thing. So getting to that level, yeah, we had to make you right. FP1, if we can do it predictably, is more cleansable and the best if you have to dentulate someone. But on him, with his level of animation, that my prosthodontist didn't want to, or didn't think I could give him the support to make his FP1. Yeah, actually that was our first case together, so it's building trust He didn't trust me 100%. We just met because the colleagues are moving all the time in the military. So thank you.
Thank you very much. Yeah. Thank you very much. On behalf of the committees, we would like Associate Professor Joseph Capetillo, the of stage, and we would like to invite our co-chairpersons, Associate Professor Vituti, to be on the stage and to give a gift and certificate for the speakers.
Yeah, thank you.